Export Lab and Dhirubhai Ambani Hospital also. Now, he has numerous national and international awards to his credit and has various research papers, projects to his credit, and has authored more than 62 articles and 22 textbooks chapters, and has a repute of being done, having conducted over 1,000 successful epilepsy surgeries in the past, whereas he has also established epilepsy surgery program at Sri Chitra Institute, National Hospital Colombo, the Riyadh Hospital in the Kingdom of Saudi Arabia, as well as in Ludhiana, and also at KDAH, which is still successfully running after his initiation of the program here. Our second panelist for today is Dr. Milind Sankhe. Dr. Sankhe is a consultant neurosurgeon at PD Hinduja Hospital and Medical Center, Mumbai. He is a leading stereotactic and functional neurosurgery surgeon as well as an epilepsy surgeon. Along with that, he is currently also running the Gamma Knife radiosurgery program at the Hinduja Hospital over the last 3 decades. Now, he has numerous publications to his credit, as well as he is an avid marathoner. Welcome, both of you, sirs. And without further ado, I would move ahead with the talks for the today by introducing each of our speakers. Now, before we begin, there is a small announcement which I had been reminded over and over again to mention, that kindly restrict your talk to the time slot allotted so that we can finish up the program well in time. And so now the plan is that we will be giving each of the speakers around 20-25 minutes time to speak, and then we'll have a 5 to 10 minute session of question answers following each of the talks. So to begin with, our first speaker today is Dr. Ravi Gopal Verma. He's a director at the Global Center of Excellence in Neurosciences and a lead consultant neurosurgeon at Aster Hospitals, Bangalore. And he has been instrumental in establishing the DBS programs at MS Ramaiah College, NIMS, KEM Hospital, and Apollo Hospital, Hyderabad. Further, he has numerous awards to his credit, as well as he has been organizing this annual workshop of surgery for movement disorders since 2010. He has been representing the field of neuromodulation to the public in as a lead speaker at various prestigious summits as well as events, and has over 51 publications in index journals and has authored 3 chapters in 3 different books. So Dr. Verma would be talking to us today about his topic for that is DBS for movement disorders. Dr. Ravi, please, you can take the dais from it.
Thank you. Thank you so much. Thank you for the invitation and the very generous introduction. I'll just put my thing on. Are you seeing the screen?
Yes, Dr. Verma.
Yes,
we are seeing.
visible.
Yeah.
Okay. So once again, I thank the organizers, and very glad to be here. I'm just fixing the timer so that. So I've been asked to speak on functional neurosurgery and I mean DBS or in the realm of functional neurosurgery. And so I thought I will talk a little about DBS for movement disorders, especially in terms of dystonia and Parkinson's, and maybe show a series of pictures on how I do it in a particular way, because different people do it in the different ways. And but ultimately, the aim is to get a perfect position of the electrodes, be it for Parkinson's disease, dystonia, tremor, or whatever. So I will talk a little on STN and then a little on GPI, and then how generally we plan the procedure and how it is done, and maybe a few cases after that. So just the basic steps is first we do a preoperative MRI depending on what we need. For example, GPI we need certain images. For STN we look at other types of images, and it varies from nuclei to nuclei. Then we after we plan it in MRI, we a couple of days before the surgery we would plan the whole procedure. Then on the day of surgery we would put the frame, and then subsequently in the stereotactic realm, we would merge the two MRI and the CT scan to form to fix a get it into the stereotactic realm so we can get it into the point. And then it intraoperatively we do microelectrode recording, and also we would do the macro stimulation and then final placement of the electrode, and then image confirmation where the lead placement is done, and then the IPG battery, subsequently the programming. I would always insist that DBS should be done in combination with a neurologist. It has to be a neurosurgeon neurologist combination, and not just by a neurosurgeon or a neurologist. It has to be in concurrence with discussing every aspect, because the treatment of the patient is divided between the two. It's like I always give an example of a driver and the pillion. Always the driver has the license, but then the person sitting next to has to guide. As in rallies, you always seen there's a person who navigates. So there should be a combined effort, and that combined effort only will give a very right placement and a good result in the outcome of the disease you're treating. So the calculation of the area that we need to park the electrodes is very, very important. And there are different softwares: iPlan, SurgiPlan, FrameLink, and the stereotactic treatment planning of system from Germany. So all these are there. I have used the iPlan, and I have used also the FrameLink, which I'm constantly in touch with. And both are equally good. There's no difference there. I've never seen a difference. And the second is how you target it. So there is direct targeting, indirect targeting. In the past, it used to be indirect targeting. But now, since a lot of progress is made in MRI and the clarity, we try to do direct targeting, which is much more precise, because indirect targeting was made of the Scholten-Braun atlas. So it was a 3-brain atlas which was made years back. And nowadays, the brains from different rays are in different sizes. So you cannot give a standardization with just 3 brains. So that is why the direct targeting has become much more popular these days. So how do we go about with planning? The most important thing here is to get a proper MRI imaging, because that is very, very important. So many people, centers, they do the MRI, under GA, so there's no movement artifact or anything like that. And they always have tremor or dystonia, some sort of a movement which could come in the way of your image acquisition. So always get an MRI done. I try to get an MRI done with the patient very still. So if he's good in his own, I think that's a good way to avoid GA. But otherwise, if you have any doubt, it's always better to do it under general anesthesia. And once we do the planning, we take the image acquisition and then plan on where we are. How do we go about with the planning? The first thing we always have to define is the ACPC line, the anterior commissure posterior commissure line. Because even in the atlas and many of the targets within the brain, even before we had all these fancy MRI and things like that, cut sections of brain used to use the ACPC line as the center point. So the ACPC line is marked, the mid-commissural point is marked, and all the nuclei in and around this area are are calculated using this very standard marking. In the past, they used to do a ventriculogram to find out which is the AC and which is the PC. I think Benabid even to date does a ventriculogram to find out exactly these details, and that's supposed to be very accurate. But again, as I said, the imaging has become so good that we really don't need to do a invasive procedure like a ventriculogram, and nowadays we do it with the help of very robust software that we have. So once the ACPC line is marked and the whole brain aligns to the ACPC line, and then we can do the marking visually. How do you see the nuclear very well? This is just an example of how we can see the nuclear very well. So you can put it in your FrameLink software which you have and get it marked by checking the level and the width. So you get a 50-50 black and white width and level, and then you lift the width to a certain extent, and you can see how beautifully the nucleus stands out. The red nucleus is right here, and this is the subthalamic nucleus. This is the red nucleus. You can see how beautifully you can see the thing. So you need to just work around a little with this, and then you get a very good picture to precisely localize where the area of interest is going to be in here in case of subthalamic nucleus. So a little bit about subthalamic nucleus quickly. It's a small lens-shaped nucleus in the brain. It's about 240 millimeters cube in size, very small, 3 into 5 millimeters in length, and it's a bean-shaped stuff. So it lies ventral to the thalamus, dorsal below the, dorsal to the substantia nigra, and medially and dorsally the internal capsule is there. Laterally we have the brachium conjunctivum and the red nucleus, if you look at the STN. So if you look at the functional division of STN, you have a rostral 2/3 and a caudal 1/3. Our area of interest is the lateral 2/3. The dorsal 2/3, where the motor circuits are. So the dorsolateral part, that is this part, if you look at this is the lateral part and this is the ventral part. It is the dorsolateral part where there is a motor system where we need to park our electrode. And if that is not done, we get a lot of side effects which are not warranted for. So dorsolateral part is the largest part of the motor STN. You can see that here. This is the motor area, dorsolateral part. And you have the limbic area here if you go more medially, and you have the associated fibers if you go posteriorly. So once we decide what nucleus we have to do, and for example, targeting, there is indirect targeting and direct targeting. As I told you, direct targeting is MRI based, T2 weighted, and inversion recovery images are used. And there's via the red nucleus, also indirect, sort of indirect, but again, this time we are seeing it very directly. So Lee et al. Used the supramammillary commissure as a landmark, but the sensitivity varies from ventricular enlargement, so that is a little outdated these days. So what we use now is the post-mammillary commissure, the red nucleus, and the mammillothalamic tract to give us a sense where the nucleus is and park the STN and your electrodes into that area. So that is why this is how we do the direct targeting. You can see this is the red nucleus. So just this diagram here will show very clearly what we're telling. This is the MRI right here, the red nucleus. So we draw a perpendicular on the biggest red nucleus that you can get. So you have to scroll above and below to find which is the biggest red nucleus you can get. So there is a parallel above here and a parallel above here, and that's about 2 millimeters lateral to that. So we mark these two things and then mark. And visually, if you see, you will see this STN like that, and you can say that this is the area of interest, and this is where we need to park the electrode. Now, this is anatomically, purely anatomically, we're going by looking at the MRI and the imaging. Subsequently, we do physiology, and then we test it. So the microelectrode recording and microstimulation, we'll be able to precisely confirm that we are in the right spot. So once we find this spot here, it's approximately 2 millimeters from that intersection I'm talking about, and that's where we need to be. It's very important. If you're a little laterally, you get lateral side effects, and the whole effect of your surgery might be you have a therapeutic window which we need to achieve, which is not possible if you're very close to the lateral area where the corticospinal tract is. So one has to be very precise, and intraoperatively, you need to really assess where exactly you are in the nucleus with micro and macro stimulation. This is just to show again the anatomy, how things are. This is the STN, you have the zona inserter here, you have the internal capsule right there, you have the thalamus, you have the PPN. So all these stimulating will cause issues. You can see here the GPI medial side effects are the internal capsule, whereas in the STN, it's the lateral side effects. So this is the area of interest here, dorsolateral part of the nucleus. So if you're too medial, you have side effects. If you're too lateral, you have side effects. So it's very important that we are precisely in the position. So that is where a neurologist comes in, and we keep increasing the the amperes, and then they will tell us what is the beneficial effect and what are the side effects. That's what we assess during intraoperative assessment of whether the position is right or not. So medially, we have diplopia, eye closure, deviation of the eye, dizziness, and all these things. And primarily the the leg kinesthetics and all that, you have a lot of issues. Dysarthria, muscle contraction, if it's too lateral because of the subthalamic sorry, the internal capsule. If it is too anterior, then we have, you see sweating and panic when you stimulate these things. That's because of the thing being very close to the anterior fibers of the SNR region. Then we have, if it's too posterior, then you have paresthesias, and posterolateral, you have effects from the dorsolateral part of the internal capsule. So once you place, this is how the electrode looks. This is a three-dimensional picture where we can see that the exact placement of the electrode is in the dorsolateral. The red part is the red nucleus, the green part is substantia the yellow part is the substantia nigra, and the green is the subthalamic nucleus. The GPI also is similar. It's very, very important to, it's a bigger nucleus. It's about 500 cube in size. This is how it looks three-dimensionally. And this is how the motor thing is precisely placed. So when you have to place the optic tract, you can see it's just above. So you look into the optic tract and then place the electrode along the homunculus, which is there in the GPI. It should not be too medially because it's the internal capsule, and a lateral, it's better to err laterally because the side effects are going to be less. And this is where we would like to place the electrode. And that is how this is from the mid commissural point. It's exactly lateral to the mid commissural point, and that is where is the important point place where we have to place in GPI. So how do you do this? You look at the optic tract. You can see the optic tract here, and you mark this optic tract. And if you put the crosshairs here, you will see the area should be just enough that it turns around the peduncle right there. And from there, you mark 2 millimeters straight vertically above, and that is where you need to be in the S. You can see this is the GPE, and this is the GPI. This is the tip of GPI, and this is the little more lateral part of the GPI, which we need to be, because the internal capsule is present right in the medial part. So this is how it looks. Again, if you're not in the right spot, you get different side effects. If you're medially, you have the posterior part of the internal capsule limb that will be affected, and you will have twitching and all that. In GPI, you need to go really high to see that we have no side effects because we need to be as lateral as possible. This is how it looks in the three-dimensional picture. In a SureTune software that we have, we can see what exactly it looks like. This electrode on one side is a little longer than the other, but then this is how we see, and this is how we decide which contact to be stimulated and which electrode to be stimulated. So this is how we look at it. So once the first thing we would do is, as I told you, is we finish the planning, then you check the CT. This is how the CT is taken. Most important, the frame should be placed as properly as possible because along the orbitomeatal line, the lateral limb should be equal to the orbitomeatal line right there. And it's like this, just here, so that we have the precise, there's no distortion when we take the MRI. And the CT scan is taken with zero degree. There's no tilt in the gantry at all. It's a 0 degree tilt, and contiguous cuts are taken so that we can see the brain very clearly, and that can be managed. Sorry. Sorry, thing is. Yeah, as I told you, sorry for that. Yeah, so see, once you finish the CT scan is merged with your MRI with the software, and then the neurologist, all of us should sit together and decide that the pathway is right. Once the pathway is right, you check it with your CT scan also, so that you don't have any blood vessel on the way. This is how you check the pathway. You can see this is a CT scan, the contrast scan. You can see there's no blood vessel on the way. This is very important because otherwise you can cause bleed as you pass down to your target, and we need to plan. Another thing is important, very important, is the angle. If you get the correct angle, then you get maximum STN, because STN is a very small nucleus. And once you finish that, you get this printout that comes out, which your X, Y, and Z is what you will have to place into your frame. I use a Lexel frame, but you can use even CRW frame. I always make this sheet here, which gives us a lot of information. One is all the X, Y, and Z. If there's a vessel in the side, I make a note on that. What are the electrodes that we are avoiding? I make so medial electrode to be avoided because there's a vessel right there. Then how much of STN? When do we reach STN? When do we reach SNR? Something I make again a mark, so that when we are in the operation theater, you correlate these things, and then you know you're in the right spot. Angles are very important. The mid sagittal angle should be around 15 to 20, 21, up to 25 is okay. The axial is about 45 to 60. So if these angles are maintained well, 20 and around 50, then you're getting maximum amount of STN within your system. I always let the patient be at about 10 to 20 degrees, because vertically, if you make them sit, there's pneumocephalus, which can cause a brain shift potentially. But again, that's a little and emphasized. It's not that important, but still, it's always better to keep the patient down. You can see when we keep the patient sitting, this is the amount of pneumocephalus that is there. It's a huge amount of pneumocephalus. And if you keep the patient at this point, you can see the brain plugs that hole. So CSF leak is very less, and you have hardly any pneumocephalus. Every point has to be checked and counter-checked, the X, Y, and Z, because if you miss your X, Y, and Z, then you again place it in the wrong spot. And once that is checked, you check your drive, that drive is in the right spot. See, the whole thing about DBS is every step is important, because if one step you miss out, and then you're totally in a place that is unrelated to your STN. And we have seen horrific pictures of the electrode being all the way down into the brainstem many times, because you missed certain numbers. Like this 20, if you miss when you go down to 40 and you put it at 40, then the electrode starts off deep down in the brain and you keep going down. So these are things that must be checked throughout. The burr holes are made vertical so that you can get maximum. The electrodes are put in like that. This is how you mount it on the thing. And these are the MER findings. You can see the sound, which is very clear, where you find like something on a tin roof is what they say, like crackling on the tin roof. So that's how it looks. So you have to get good firing. So you make a mark of where the firing starts, where the firing ends, so that your macro stimulation, you follow that rule. Then you make a picture like this, where you draw your electrode on the side and say, okay, this is where you got maximum firing, and then you place the electrode in such a way. After you assess the macro stimulation that you're in the right spot, you place the electrode. Placing the electrode, very important. There are deviations that can happen. One has to be very, very careful while placing. You can see this is how the electrode is placed here, but when you remove that and place the electrode, there is a deviation. So that has to be really counter-checked and seen that it goes in the right spot. And always confirm CM, keep your CM guidance there throughout, so that you know you're in the right spot, and you can pull or push if necessary. And the most important thing is to maintain the trajectory, and not to handle it very roughly, that you can miss the target, because we are talking about very, very small targets. In our institution, we have an OAM. So immediately before I take out the frame, I check whether the electrodes are in position. And this is very helpful, because intraoperatively, only before even taking out the frame, if there is a malposition, we'll be able to rectify it right away. So here, this is how it is. And we check it before we take the frame out. We check it whether we are right. So you can see this white dot, that is the electrode that's been placed there. And you can see it is going all the way down. And this, I get this in the operation theater before I even take the frame out. you can see exactly where the red nucleus is, and this is where we had planned it to be, and it is precisely where it is. And then, of course, tunneling, every aspect, as I told you, is important, because one tight screw, one breakage of a little electrode, you might, these delicate electrodes, you can have issues. This is a patient that we had operated with, most important thing is what they feel. It's very important to take an assessment before we do these surgeries that, look, you're not going to run and become an Olympic champion with this. You need to understand that you're going to be better off. But you can see this man smiling, but he was not happy. He said, I'm not very happy with what is happening. Can this be done? I don't think I require DBS because I'm doing well. Because he was taking some amount of medication. So we switch off. Each of these times we switch off. And then you can see the difference on his face. You can see his face suddenly, he has lost his smile. You can see that which was there, and he's not able to walk. You can see how he's walking. This happens instantaneously. And this gives him an assessment. When we tell him, you look, we have switched it off. Now you can go if you think DBS is not going to work. And it's very, very important to show them that there is work, because they all have large expectations, and that is very important to put them to the right spot. So you can see this. He's got his tremor there. Then we switch it on, and then you'll see what happens. So the reality check is something that we must do. So they should realize that you're not going to be fantastic, but you're going to be much better off than what you are. So this is now switched on, and you can see how his tremor sort of stops. And you see he's much happier. And in fact, after this, his wife was very happy, because if he talks too much, they switch him off. So that is what happens here. So yeah, this jokes aside, this is what it makes. You can see the difference when he's on and when he's off. This is a person who had extreme high tremor. You can see the tremor, tremor dominant PD. Just see, we switched it off, and this is how he is. 24/7 of his awake time, he's like this because of, this is tremor dominant PD. It is not essential tremor or any of those things. It's tremor dominant PD. So we parked it in STN, and you can see when we switch it off, how it works, and then when we switch it on, it all becomes normal. So this is how DBS really works. The long-term outcome of DBS is now emerging to be doing well. I mean, in fact, Parkinson's patients, it's really doing well. For many new indications are coming in. Dystonia, it is working well, especially for primary dystonias. Secondary dystonias, to a certain extent, we have done a few. And failures are because, one, surgical selection is very important. That's why it's very important to have a good neurologist, movement disorder neurologist, who can help you in this situation and select the patients correctly. You also come to check, have a discussion, and then things will be a systematic workup, follow protocol, surgical procedures. 140, 150 steps are there, which are to be completely checked over and over again whether you're in the right spot. So then we can prevent failures of DBS. This is a book that we have written, where we have Dr. Sujit and myself, and we have all these points there noted for programming in each of the movement disorder cases. Thank you.
Thank you so much, Dr. Ravi. This was a very succinct and to the point demonstration of the surgery, as well as a lot of nuances about the surgical technique you had shared in this talk of yours. I would request Dr. Milind to just comment about the talk and share a few of his experiences with respect to the DBS surgery that he does. Dr. Milind?
Hello.
Yes, sir, you're audible now.
Yeah, hi. So, as listening to this, practically speaking, what Ravi has been saying is, and giving you the information, there was a question, Ravi, which was regarding use of frameless stereotaxy and conducting DBS. Do you want to make a comment on that, Ravi?
Yeah, I can make a comment, but frameless stereotaxy is, the precision of frameless stereotaxy is still in question. There are frames that can be made to the patient's liking or to the patient's head. There's made, you can make an order and have one very custom-made frame called an X frame. But otherwise, frameless stereotaxy, like a frameless biopsy using navigation and things like that, I think his precision is still in question, and I wouldn't think that would be precise at this point.
Yeah. So one of the reasons I put that question is because I've been, and a lot of us have been doing this for so many years. The accuracy with frameless stereotaxy actually manages to get the targeting precision is still in question at many centers across the world. And the use of frameless stereotaxy is very appealing, but the precision that the frame-based stereotaxy achieves is something which is, because this, we are not talking about even a 1 millimeter shift here and there can make a big difference in the outcome, and that's the reason why we are talking about directional leads in the STN in particular. Any other questions on the chat box?
Yeah, Akshat, can I ask a question to Dr. Verma and Dr. Sankey, if you allow me?
Sure, sir. Please.
Yeah. So that question is on a chat box as well. So Dr. Verma, many of them in the peripheries I've seen, they don't do microelectrode recording and macro stimulation. They just target the STN or GPI based upon the indication and just place the electrodes and come out. How effective is this? And many of the peripheries I've seen, they're doing these things when they don't have the facility for microelectrode recording. How safe and accurate is this?
Yeah. Now this is a debate that is going on for a couple of years now. It's called awake versus sleep DBS. So what you just mentioned was a sleep DBS where patient can be done under GA. You just place it anatomically in the right spot as we were discussing, and then come out and then see what the results are going to be. There are two reasons why I don't, I still don't believe in that as much, and I'm a little worried, is because, see, each nucleus for each person is different. The homunculus is different. The cytoarchitecture is quite different. It's like your fingerprint. I mean, every nucleus has a different cytoarchitecture. Now, you just randomly place it at some point which you think is the right point without knowing whether stimulation-wise you're right or otherwise you're right. And then, it's an expensive procedure. And then you take a chance and leave it to chance. And I wouldn't be comfortable at all. I would like to see the patient improving on table. I would like to see whether I'm in the right spot. We go with 3 or 4, even 5 electrodes at times. And then we want to know exactly which is the spot, which is the sweet spot, because it varies from person to person. And also I have noticed in my series, I've done about 300 odd DBSs. In my series, it is only about 40 to 45% that I've used the central, which is bang on target. Near another 25 to 30% I've used the anterior channel. So I'm still not convinced. If I get every time the central target, then I would have thought, okay, we can do it, because central target is 100%. I'm hitting only the central target, central line, and I will place it there. Then that makes sense. But I'm still not convinced of doing an awake. But with the advent of newer modalities of MRI, higher Tesla MRI, more precise understanding of the nucleus, maybe at some point we'll be able to do that. But I'm still wary about it.
Dr. Sankey, can you comment on that?
Yeah, so maybe a slight difference of opinion from my side on this. Regarding the use of, I'll try and break this argument down in 2 parts. One is an asleep DBS and other is a use of MER as such. So asleep DBS is a concept which has been present in the DBS world for many years now. It's been going on since the dystonia work started. And a lot of surgeons have been doing asleep DBS for dystonia, but that was primarily for the GPI as such. Now, the problem comes is that STN is a much smaller nucleus than the GPI. Now, given that the size of STN is just about 6 millimeters, and it has it has some sort of, we have an understanding where we know that dorsolateral STN is probably better. But as Ravi said, that it is not necessary for everyone to have the same sort of cytoarchitecture. So one needs to understand that there is a role for asleep DBS, but may not necessarily apply to STN as such every time. Now, the concept of MER to be used in the earlier days when GPI being such a large target, a lot of individuals would just do it straight. And some of the old work, the oldest publications or some of the old publications here was by Philip Coops. He was actually one of the from Montpellier who was doing right, left, and center without an MER, straight placing the target into the GPI, or for that matter, then he started moving on to the STN as well. But I remember talking to him, and he very clearly said that I am a very strong advocate of doing a DBS without an MER, but he did not actually wasn't very comfortable to say that everyone is necessarily asleep, and that was particularly with the STN. Now, use of MER as such in GPI or for that matter in STN, that was also a major point of argument in the past. In the past, people would say GPI recordings are not easy, but we now all of us are aware that that's not true. You can get as good a recording in the GPI as you can get in the STN.
Yeah.
So if you break down the argument in two parts as to use of MER, I think it is a choice for the surgeon and for the team. But now, to express solidarity with what Ravi is saying, I do MER with every case, irrespective of whether it is an STN or a GPI. It's a protocol, I will do it. Having said this, a lot of the times I would slightly differ with Ravi on this, that it may not be 40 to 50%. Maybe I try and get centrality around 70 to 80%, 60 to 70, I would say around 70%. But, and now we are talking about roughly around 250 to 200 to 250, I would say about 250 DBSs, so around 500 placements, sort of a thing.
Yeah.
And we are talking about lesioning as a separate thing. Now, we are, centrality by itself in 70% does not necessarily mean that you stop the use of MER, because there are still about 30 to 40% individuals who still would, you would choose a different trajectory. As Ravi said, a lot of the times he lands up taking up the anterior trajectory. That is purely MER based, because he is actually thinking in terms of doing an MER macro and the do them with MER. That's the protocol that I follow. I have no hesitation in saying that a sleep DBS is possible, but would I do it for all STNs? I would probably say no. GPI, I would probably say yes, it is easier for me to do a GPI in an asleep as well, because I just need to try and make sure, because the amount of side effects, if you are going to look after the internal capsular side effects, there are no issues as such. So I tried to break down the question into two parts so that there could be a little more discussion and clarity on it. But I think both have a role. A sleep DBS is much faster, but does not necessarily make it better for the patient.
Yeah, very true. But again, one more point, I think, with this insight, that is the new directional leads, maybe a sleep would be a little more safer, because you can place it and then change directions accordingly, and then maybe that would work. But I'm still in favor of awake. In STN, definitely in STN. GPI and some dystonias, we have to do it under GA. Sometimes we do it under GA without getting any we do the MER, but we don't do the macro stimulation at times, because they will pull themselves off the frame and things like that. But definitely in STN we would do sleep. We wouldn't do
practically what we are saying is that more or less everyone with experience tries to come down to the same thing, that do which can be individualized, what you're comfortable with.
Yeah, when something is fixed, not broken, don't fix, sort of situation.
Absolutely. If something is working well, why change it?
Yeah, exactly.
So there is another
Akshat, over to you.
Yeah, there is another question for you, sir. How is DBS better than MRI guided focused ultrasound? So usually it is the other way around. And again, it is the hornet's nest that
Ravi, Ravi, do you want to have a go at it? Go on.
You can go on and on with this, but then one is lesioning and other one is stimulation. That is the basic difference. And if you spend so much of money for your lesioning with an ultrasound, we can lesion with the RF, which is going to give you the same benefit, and it'll be much cheaper. And I mean, the same thing. You can tailor and make a beautiful lesion with your RF, and only difference is you make a burr hole, which you don't need to do in Fusa, and burr hole really doesn't matter. But if you want to be non-invasive and do a lesioning, then you can use your Fusa. Yeah, but it's a big difference between lesioning and stimulation, which is to controversy. I think we can have a whole session on that.
Absolutely. So one thing which, apart from what Ravi said, cost. One is lesioning, one is the presence of burr hole, money, everything. But lesioning for STN? No. Absolute no. You don't want a patient to become ballistic. Definitely not. And
Yeah.
bilateral STN? No chance. You can't do that.
They would suffer Parkinson's.
Just because a few papers have been published does not make it necessarily the right kind of treatment. No.
And
Go on, Ravi. Sorry.
You have STN lesioning. You can be much worse than PD. He'll suffer PD for the rest of his life, but he'll never suffer the side effects that you can have with bilateral lesioning. It is the most devastating thing that you can do.
So the indications are different at the end of it all, and these two things are to be talked separately at all
No,
times.
so to take your argument forward, Akshay, just a point in favor of MR guided focused ultrasound, apart from the fact that, yeah, someone who really has a phobia about getting operated upon, has purely a tremor, which is the only interesting point. He is going to do a Wim thalamotomy, different ball game. That's a different ball game. But I would argue to the last point, as far as someone suggests STN STN lesioning, I would definitely argue right, left, and center. To the last statement, I would say no to this.
But they would
But
always
with thalamotomy,
propose a pallidotomy, sir. They would always propose a pallidotomy for this thing as
pallidotomy again, bilateral pallidotomy is a no.
Big no.
Yes. Unilateral disease, so unilateral Parkinsonism. They may propose that you can go for a unilateral pallidotomy
But
as well.
then
So
the
again,
argument
the
comes is the
indications
fact
are
that
very,
you're going
very
to do it.
limited and niche. We have to tailor them for the patients. We agree.
And if you're going to talk about something as a unilateral procedure, then you're defying the basic understanding of Parkinson's, that it's a symmetrical disease.
Parkinson's is always bilateral.
It's
It
a
might start
bilateral
from one
disease.
side, it goes
Not
to the other side.
symmetrical, but it's a bilateral disease. And eventually, at some stage, you're going to need something else, no, along with that.
Akshat, Dr. Dattatreya is waiting. Can we move on to the next now?
Yes,
Talk, please. Yeah, thank you.
Thank you so much, Dr. Ravi and Dr.
Thank you. Thank you.
I request Dr. Dattatreya to our next speaker for the day. And Dr. Dattatreya is a professor of neurosurgery at St. GS Medical College and KEM Hospital. He is also the lead in the comprehensive epilepsy care program at the institute. He is heading the neurosurgery chair at the Cooper Hospital, Mumbai, and has a teaching experience of over 23 years with over 175 publications to his credit. He is on editorial boards of various journals, and today he will be talking to us about his talk, which is titled "The Surgical Consideration for Mesial Temporal Lobe Epilepsy," and he would share his perspective upon it. Please, sir.
Dr. Majumdar, you are muted. Can you unmute yourself, please? Yeah.
Okay, can you hear me now?
Yes, yes. Now go ahead.
Okay. Thank you, Abhay and MCNS for giving me this opportunity to speak on the very common topic and a social disaster. It is as bad as the Parkinson disease. So, without wasting any time, I would I'm going to talk only of mesial temporal lobe epilepsy today. So, the Comprehensive Epilepsy Care Center at KEM was started in 2000, and you can see Dr. E.P. Barucha, Dr. V.P. Mondkar, Dr. Piyusha, who started the epilepsy surgery care program, and Dr. Sangeeta Rao. The program was started in December 2000, and it was inaugurated by Dr. Polki, as you can see in the picture. And also the Center for Neuropsychology was started with Dr. Urvashi Shah at the helm, as you can see. And obviously, it's a collaborative epilepsy surgery program, which is very well known. You can see Hughlin Jackson and Horsley making a team, Penfield and Rasmussen making a team. So here, everything works in a comprehensive board, and the epileptologist is the leader of the team with MRI radiologist, neuropsychologist, psychiatrist, and recently we have added the nuclear medicine also to the armamentarium. So we have an experience of about 650 plus cases now in 22 years, and adult and pediatric, both temporal, extratemporal, and we have a long-term follow-up about more than 10 years in about 200 cases. Let me tell you in conclusion that the results have been very gratifying as regards seizure control, seizure freedom, and quality of life. All our experiences compiled in this 2016 supplement on epilepsy surgery in the International Journal of Surgery. We have over 10 articles depicting about our experience right from surgery to neuropsychology to epilepsy surgery outcomes and even the nuclear medicine as well. This is a very standard slide which everybody puts in their own presentation, and it has been Dr. Radhakrishnan has done this exhaustive survey, and it was published in 2015. This still stands, and you can see that there is still a lot of potential for epilepsy surgery in India. And I think we have progressed a little bit, but maybe there is still a long to go. Dr. Bhaskar would be better person to speak on this. But I think there is a lot of scope for epilepsy surgery still, and more centers, dedicated centers should come forward in this aspect. So if I come to the mesial temporal lobe surgery, there three things come in mind. So one is the mesial temporal lobe, the lateral temporal lobe, and the medial. The mesial temporal lobe is all confined within the temporal horn. As you can see, there are intraventricular structures. So all the structures are new to a general neurosurgeon, but as you go deeper into epilepsy surgery, these things become a routine. So we have to take out the epileptogenic structures. So they are the hippocampus, the amygdala. We have to know the extraventricular structures like the uncus, the parahippocampal gyrus, dentate gyrus, and so on and so forth. So you can see in the bottom side, you can see the MRI picture depicting the sclerosed hippocampus very nicely. You can see the arrow pointing to the temporal horn, which is dilated. You can see that the hippocampus has lost its digitations as compared to the opposite side. And you can see that there is a little bit signal change in the hippocampus. So that hippocampus is certainly diseased. And you can see because of the atrophy, the temporal horn dilates. And you can see in general, the entire temporal lobe is also atrophic. So there is a striking difference between the right and the left temporal lobe. And if you understand the function, if I tell the hippocampal anatomy, the mesial temporal lobe structures are connected to the entire, it's a circuit. And hippocampus is mainly concerned with the consolidation of memory, and it's mainly episodic memory. So there is a role in formation of new memories about past experiences, very important. So although we consider hippocampus just a gateway of generating epileptogenic phenomena, it has got certain role in episodic memory. You can see, in addition, The medialmost part is the subiculum, which has got a role in working memory and drug addiction and so on and so forth. So entire circuit, like from hippocampus to parahippocampal gyrus and to the fornix and to the limbic system is what is we are hinting at when we disconnect. One of the most important structures is amygdala, which is a very precise small structure, and it has got a medial and a lateral part. Amygdala itself has about 12 nuclei. So you can imagine that the amygdala is also connected. It is basically concerned with emotions, positive and negative, sexual arousal. It has role in vision, smell, hearing. It is connected closely with the entorhinal cortex. It is connected with the opposite amygdala. It is connected with the hippocampus and then the hypothalamus, septal region. So it's way right up to the cortex. So you can imagine all these mesial temporal lobe structures through the Papez circuit is connected with the cortex as well. And you can see here the pathway for emotion, memory, and seizures is more or less the same. And you can see in the bottom right side, you can see the entorhinal cortex and the cingulate gyrus. It is connected via the parahippocampal gyrus. And obviously, all these epileptogenic phenomena, all our emotional behavioral stimuli, all this pass through the medial temporal lobe into the thalamus, mammillothalamic tract, and internal capsule, cingulate gyrus, and the cortex. So all these things are extremely crucial to understand before we make a lesioning in the medial temporal lobes. You can see that the amygdala is seen here, the hippocampal formation. You can see how the hippocampal formation is connected with the cingulate gyrus and back to the mammillary bodies, thalamus, and from the thalamus it is all connected to the internal capsule, to the motor and sensory cortex. So you can see when we talk about a mesial temporal epilepsy, it is a disaster, and this is the reason that it is a disaster, because it entails a lot of medical treatment, ICU visits. There are socio-economic concerns. There are a lot of cultural, custom, religious considerations, and obviously the hidden parts. It's not only the seizures, but the psychiatric part, emotions, behavior, neuropsychological aspects like cognition and memory and intelligence are also affected. And now, this is one of the very few surgical studies where there is a clear cut. The two randomized studies, one done from London, Ontario, by Sam Weeb and by Jerome Angel from Los Angeles, have clearly proved that surgical treatment for medial temporal epilepsy scores over medical treatment. I would urge people to read this New England Journal of Medicine 2001 article, because it beautifully explains how, and a very properly conducted study, that how surgery is definitely effective over the controlled medical arm. So why we should operate early in medial temporal lobe epilepsy? Because we get freedom for seizures, we get freedom from drugs, and we basically avoid two aspects. One is the SUDEP. Sometimes these patients have sudden death, the SUDEP syndrome, and maybe one big seizure, or normally it doesn't happen in MTS, but sometimes secondary generalization. Sometimes the patient gets a cluster of seizures, and patients can die in sleep as well. And other thing is, over a long period, if you don't address this problem, it kindles the other side also. So if you don't address the unilateral side, the contralateral side gets affected. The efficacy of epilepsy surgery goes down from 80% to 50%. And if we address the problems at right mode, then you can definitely look at an enhanced quality of life. More so, a burden of normalcy. These patients are integrated into the society, and then they feel the heat of normalcy, and they have to be rehabilitated from that point of view as well. So pre-surgical evaluation, I'm not going to go into detail of this. We should have a good history exam, seizure semiology, EEG, video EEG, and MRI or neuropsych. All these things should have a congruence. Now, if it has congruence, then only the patient will benefit maximum from epilepsy surgery. And there cannot be any shortcuts for this. It has to be done properly in a proper center, under a proper collaborative program. And there has to be counseling, there has to be discussion, and it cannot be a one-time surgery done in an isolated place, because then the efficacy is not only a temporal lobe surgery that we're talking about. We're talking about the entire paradigm of epilepsy. And usually, mesial temporal lobe surgery can have, in addition to the mesial temporal lobe sclerosis, you can have several other low-grade lesions which are there since birth, developmental lesions and vascular malformations, from traumatic atrophic scars, arachnoid which are incidentally detected, which are associated with hippocampal atrophy or sclerosis. In my practice, when I started doing MTS, I was only exposed to MTS, mesial temporal sclerosis only. But then I found that there is certainly MTS has got a polar dysplasia. The temporal pole is also appears to be very hard and firm. So there are two aspects to it. Either it's just reported as a gray-white cortical blurring, or there could be a real dysplasia in the temporal tip, which is the cause, is the precursor for MTS. So that has to be differentiated by a good pathologist. Then sometimes an intense sclerotic hippocampus is there, which is very bright, and it sometimes causes very difficulty in surgery as well, because separation of the hippocampus from the surrounding tissues can be really challenging. And obviously MTS plus, when we have a lot of when we have other lesions, when whether to remove the hippocampus or not, along with these lesions, also needs to be understood and thought about. Then bilateral MTS is another entity which has a separate topic itself by itself, but I'll just touch upon bilateral MTS in a short, in one or two slides. So here you can see hippocampal sclerosis can come with a very different aspect. So it can come with anterior polar dysplasia. Therefore, is sometimes diffuse cortical dysplasia involving the entire temporal lobe, lateral as well as mesial. And sometimes the landmarks are not very proper, and then it's very, very difficult to locate the temporal horn. Sometimes we have to use the navigation, and it can be a very surgical challenge because the cortical dysplasia, which is diffuse, it almost like a low-grade glioma or a infiltrative glioma, which we have to be very careful with dealing with the critical neurovascular structures around. Bilateral hippocampal sclerosis, which one to remove, which one not to remove, is also a consideration. And as I just mentioned about the left side, you can see that there is a very sclerotic, or it could be atrophic or very dysplastic hippocampus. So the hippocampal architecture also has a surgical challenge. Sometimes it may be just a very firm, soft to firm hippocampus. Sometimes it can be very sclerotic. Sometimes it can be very dysplastic. And as I just mentioned, MTS can come with various other things. It can come with a temporal lobe atrophy. Sometimes the patient has got a bygone trauma. It can come with a subdural hematoma, and we can the patient has concurrent MTS, or MTS always as a sequelae can have the atrophy of mammillary body and the other structures in the Papez circuit because of the long-term sequelae of epilepsy surgery. So as I just mentioned, these are the surgical challenges. In addition, also amygdala or uncal mass lesions also provide a challenge because they skirt the hippocampus. So whether we have to address only the amygdala and the uncus or remove the hippocampus also requires a lot of detailed consideration. So when I do considerations only for amygdala hippocampectomy, it matters whether we are operating on the right or the left. The right side, we are very generous. Most of the time, the right side visual memory, if it is down, even if sometimes the visual memory may be a little bit near normal also, sometimes we take the chance of doing a right ATL. But on the left side, we are really very careful with the neuropsychology, whether the memory is intact or impaired. And obviously, the anatomical proximity of the lesion with the mesial lobe structures bears an impact. I use intraoperative ECG on the hippocampus if suppose the surface ECG recording does not give any good spikes. And obviously the hippocampal structure, the socioeconomic strata of the patient, occupation of the patient also has a bearing. So remind you, these patients cannot come again and again for surgery. What we have to do, unlike the West, we have to offer a one-stage precise surgery where the patient would be freedom from seizures. Maybe the drugs, maybe the patient may be on one or two drugs, but the patient usually who comes with a long-standing epilepsy with 4 or 5 drugs. So the occupation of the patient and the socioeconomic strata also has a bearing on our surgical strategy. So there are various procedures. So I just mentioned about the standard ATL. Sometimes selective amygdala hippocampectomy done, but it is not favored as far as in our country because we see a lot of lateral temporal lobe foci as well. And obviously, there are some people who just do functional disconnection of the temporal lobe. Sometimes they keep the hippocampus, do multiple transactions of the hippocampus and keep the hippocampus inside. Usually, it is done in the European continent, but as a protocol, we don't favor that because our patients are different from the patients that we are seeing in the West. So our goal is complete seizure freedom, and there cannot be any added deficits for sure. And we have lot these benefits of surgery which I just mentioned. And there are special situations. Now, there are young women who are considering marriage, want to get rid of epilepsy. There are divorce, or there is a precondition for divorce. Pregnant patients can have MTS. Patients who want to pursue higher studies also want to get rid of their surgery, of their epilepsy. Or it could be a prerequisite course for professional courses and higher executive functioning. So sometimes if you have appearing for a degree exam, the examination panel will not allow you to appear for exam unless you get treated for your mesial temporal epilepsy. So there are apprehensions which we have to consider. We sometimes have to do functional MRI for dominant lobe lesions. We have to do cognition, intelligence, level of functioning, and obviously the intact memory patient who have an intact memory profile and we have to operate. We have to see whether the removal of the hippocampus in certain select situations will will allow the patient to function in a proper manner in the post-operative period with the strategies which are taught by the neuropsychologists. So I take a standard incision, a question mark, with a standard temporal lobe. Some people do take linear incisions as well. And obviously the frontal branch of the facial nerve is preserved, and the dissection is avoided in the facial layers. You do a craniotomy with the anterior and the basal exposure because I need to go at the temporal pole. So it's a very small craniotomy to start with. It is obviously the standard landmarks of temporal lobe apply 4 to 5 centimeters on the left and about 5 centimeters on the right. And I use a middle temporal lobe gyrus approach and straight away head to the temporal horn from the middle temporal gyrus. You have to open the temporal horn. So you could either open it from the inferior temporal gyrus, or you can go trans-sylvian, or I prefer the middle temporal lobe gyrus because I feel it's a straight approach, straight about 3 to 4 centimeters, and you are into the temporal horn. So I do a subpial R block resection if preferable, and there is absolutely no transgression of pyometer allowed. I hate if the pyometer is transgressed. There is minimal retraction of the temporal lobe. So these are the standard steps of surgery. You have to safeguard the vein of Labe. Just a small video, it's a highly edited video. You can see that this is the middle temporal lobe, middle temporal gyrus. So do a corticectomy. I just mentioned it's a highly edited video. So about 3 to 4 hours of surgery is condensed into 2 minutes. So you can see I just do a subpial resection and just enter the temporal horn. If this temporal horn is entered, then this is the, you can see the hippocampus, and I just resect the amygdala first. You can see the amygdala resection, the line of resection is arbitrary. You have to resect through the outer third, the inner third. You have to see that you don't transgress posterior and superior to the inferior coronal point. Because if you go there, then you might just enter into the deeper structures, and you can injure basal ganglia and so on and so forth. So you can see the pia is seen down. I don't transgress the pia. You can see the amygdala. This is the amygdala. So this is an amygdala separation. Then I come into the hippocampal sulcus, which separates the hippocampus from the parahippocampal gyrus. You can see that this is the hippocampus staring at you with the choroid plexus. I make an incision on the tail of the hippocampus. I cut the tail. Now the tail can be cut at the level of at the posterior aspect of the midbrain of the mesencephalic sulcus. Now, sometimes there is an argument whether you need to cut the entire tail or leave a part of the tail. Sometimes the residual tail is considered to be important for reorganization of the memory. So you can see here that the entire hippocampus and the parahippocampal gyrus is excised. And you can see that the pia will be soon be exposed, and the hippocampus is just swept off from the hippocampal sulcus. This is a highly edited video. The student should not get confused that this is a very easy surgery. Just for the sake of time, I have done this highly edited video. So you can see on the anterior aspects, you can see the anterior coronal artery, the optic tract, and the third nerve after you remove the amygdala and the uncus. And you can see the PCA through the pia. And then after I've disconnected the hippocampus, then you can see that the temporal lobe, lateral temporal lobe can come off without any ease. So here at the anterior aspect, you can see the anterior coronal artery. And the whole temporal lobe, then lateral temporal lobe can be delivered safely. And you can see the tent and the structure. The brainstem is also seen below the midbrain, will be seen below the line of resection. So this entire specimen comes out, and you can see that the intrabuccal is done. Usually the neurologist is there inside of this thing. We do a single strip 4 contact point electrode. Obviously, it is extremely useful. It helps to extend or limit resection. We avoid chasing the spikes, and it is not a predictor of seizure outcome, but definitely it helps for us, especially when we do a lesionectomy with MTS. So this is the entire specimen which comes out. You can see the temporal lobe, parahippocampus, gyrus, hippocampus. The pathologists like to see the specimen oblong instead of small bits. And the post-operative, the normally patients do have some transient fever, headache, but it just settles down. Sometimes these patients can develop something like there is an anterocortical injury, or you can develop thalamic infarcts. So we have to be a no. It has to be. This is one of our very early patients when they had developed a thalamic infarct. It took about 2.5 months to recover. So you can see that we don't want to see such kinds of MRIs in our practice. Normally, surgery is very safe in experienced hands. Mortality is less than 1%. Hemiparesis is less than 1%. Normally, patients do get 17% of the patients do have visual field defects, which are not subjectively brought out by the patient. But on visual testing, you might find some visual defects, hemianopia. If you go very posteriorly and damage the Layer's loop, then only you can have this. Otherwise, most of these patients do not complain of any hemianopia. So if the patient develops persistent postoperative seizures, then obviously there is a low-grade tumor which has been missed. Sometimes there is a residual mesial temporal lobe structures which are not evaluated properly, or the epileptic zone is extensive. The pathology is not. So these things need to be addressed in the postoperative. But definitely, post-operative seizures or no residual hippocampus does not mean that patient needs to undergo repeat surgery. It has to be evaluated again in a proper multidisciplinary program. So I think the advantages are quite good. The 10-year, the initial 2 to 5 year rate of success is about 80%. But I must let you know that at 10 years, most of these patients with complete seizure freedom with complete withdrawal of drugs is, in our experience, has been about 55 to 58%, which is on par with what we see in the world. And obviously, not looking at a long-term data above 10 years. So definitely, this surgery has a very gratifying outcome. Bilateral MTS is a different topic. I don't want to get into the details because you have to select. We use a non-invasive protocol, and we look at the hippocampi, the asymmetry of the hippocampi, and then decide, short of any depth electrodes or stereo EEG, we decide with certain parameters whether which side is suited for the MTS, or which side we have to operate. So definitely for our 35 patients with bilateral MTS, the results have been good. If the patients have the best outcome is on the patient who has got unilateral interictal and ictal EEG discharges. And if there are bilateral discharges with bilateral independent zone, then the outcomes are less favorable. So I think, do I have time for 2 or 3 minutes, Abhay? Abhay, do I have time for 2 or 3 minutes?
Yes, go ahead, Dr. Majumdar.
Got 2 or 3 minutes and I'll finish because it's already 25 minutes. So with lesions also, if there are lesions, it's a very difficult problem because it appears that if there are lesions and if there is a signal change in the hippocampus, whether to remove the hippocampus or not. So when I remove the lesion along with the medial temporal structures, if the anatomical proximity is too close, and sometimes it shows it is very dangerous to leave the hippocampus inside if the lesion is close to the hippocampus. Now, then I do the intraoblique. Obviously, if it shows spikes, we remove it. As I just mentioned, right-sided lesion with normal and abnormal profile, we are generous in doing a standard ATL. And obviously, there are some hippocampal abnormalities which are visualized on a detailed imaging, not the usual MRI. So in those cases, also we do hippocampectomy. And if it is only lesionectomy, then what are my parameters? So I have to see normal white matter around the temporal horn. The intra-op ecology should not show any epileptiform activity on the hippocampus, and left-sided lesion with intact verbal memory profile. These are the things where I will not touch the hippocampus. The threshold for touching the hippocampus is very, very high. So we take these decisions in a consensus group meeting and intraoperative. And here are certain examples. So now there is an arachnoid cyst with dysplasia in the basal temporal structures. We have to do the ATL. Sometimes you have the low-grade glioma with hippocampal cortical thickening. We do the intraoperative imaging, then we have to do it with ATL, the post-op. This has to be done to give a completeness of surgery. Sometimes there is a heterotopy at the temporal lobe, which is just below the hippocampus. Now it can be missed. So if it is better to do a complete ATL to avoid recurrence. So if you leave just remove the heterotopy and leave the hippocampus inside, then the hippocampus may fire later and it will be a problem. Sometimes the FCD is extratemporal, parietal FCD with MTS. So at that time, the same sitting, we remove the parietal FCD as well as the MTS. And epidermoid. So with a large epidermoid, you can see the coronal fissure. There is no point in keeping the epidermoid. Right side with the memory impaired, just do a generous anterior temporal lobectomy along with the lesion. So these are the things where you need to do a lesionectomy along with the medial temporal structure. So here, suppose there is a superior or medial temporal gyrus calcified granuloma with the MTS. Here you might just do a lesionectomy, and if the intraoperative ecology spikes are present on the hippocampus, although the hippocampus is normal, as I said on the right side, I will be a little bit generous. So we have found that if we don't remove the hippocampus in these cases, the patients may come back with epilepsy. So as I said, in our patient, we cannot afford to have recurrences. In exophytic midbrain glioma, memory impaired. Now here, I know that this is maybe a 2.5 grade glioma, but here also, we are generous in removing the hippocampus. So in these cases, only lesionectomy we would do if, suppose I just mentioned that hippocampal recording is normal, hippocampus is normal, then we would just not do the hippocampectomy. So I feel that there are many other aspects, but it's a very exhaustive topic, and I feel that lesions with mesial temporal epilepsy, especially the MTS, should undergo a proper surgical evaluation and a counseling. And surgery is safe. Surgery is definitely safe and effective in experienced personnel. Results are encouraging, and I think long-term follow-up is needed to determine the epilepsy surgery outcome. It should be around 10 years we are looking at. Thank you. Thank you very much.
Thank you so much, sir. And this was a very in-depth review of the entire topic of mesial temporal sclerosis and surgery associated with it. May I request Dr. Mallabhaskar Rao to just please comment about the talk as well as give his own insight on this topic.
Yeah, in fact, both presentations by Ravi and Dr. Mazumdar are very interesting and very informative. I hope young members of the MCNS will get motivated and some of them hopefully will take functional neurosurgery in the years to come. From anatomical point of view, amygdala, which is such an important part in the epilepsy network, and globus pallidus, which is an important part in the Parkinsonism, they actually merge together. You cannot separate amygdala from the globus pallidus. In fact, when we look at seizure propagation, seizure which is starting from mesial temporal area, when it passes from amygdala to globus pallidus, patient will have dystonia. And this dystonia is a very robust lateralizing sign, but it is so different from neurobiology point of view, how patients develop epilepsy, drug-resistant epilepsy, and adjacent structure people develop Parkinsonism. I hope some of the basic researchers will give us answers in the years to come. Now, Datta's presentation, as usual, very, very delightful presentation, very informative. Just few comments from my side. One is The mesial temporal lobe epilepsy with mesial temporal sclerosis is the most common substrate underlying drug-resistant epilepsy, and the anterior temporal resection is the most common epilepsy surgical procedure. In fact, if young people can learn how to do hippocampal resection, it's close to almost, I must say, close to 50% of
Yeah.
epilepsy surgery involves this hippocampal resection. Now, we say that we have millions of people with epilepsy in India, and then there are hundreds and thousands of people drug-resistant epilepsy cases. When you go for a fellowship and then come back and then want to do epilepsy surgery, not many people will come for surgery. All these people with drug-resistant mesial temporal lobe epilepsy with mesial temporal sclerosis, they're all hidden in the community. They just don't come to epilepsy surgery centers. They're all hidden in the community. It needs a great effort on the part of patients, families, their primary care physicians, pediatricians, and healthcare organizations, and then to refer them to comprehensive epilepsy care programs for evaluation, detailed evaluation, not surgery. If you tell about surgery at a community level, they'll run away from a useful operation. Even when they come to comprehensive epilepsy centers also, it's not easy even for neurologists to identify suitable candidates. Temporal lobe epilepsy syndrome is a group of disorders. There's a mesial temporal lobe epilepsy, there's a lateral neocortical temporal lobe epilepsy, there's a temporopolar epilepsy, there is occipital epilepsy, there is a insular epilepsy, there is an opercular epilepsy, there is a orbitofrontal epilepsy. All of them look like similar. So one should not make a mistake in identifying. Initial cases have to be, not initial, even subsequently, all cases have to be very ideal candidates. And young neurosurgeons should note that their contribution to epilepsy should not be technical. I mean, microneurosurgeons who are good can resect hippocampus safely without injuring brainstem, PCA, anterocoroidal artery, optic chiasm, optic tract. But still, they should know a little bit about epilepsy and drug-resistant epilepsy. And surgery also now, Datta has made it very easy and simple. But there are so many procedures that are even to resect the hippocampus. There are 7, 8 different variations are there in the technique. But you do what you are trained with, what you're comfortable. Anterior temporal resection is definitely much better than doing any sort of selective procedures, because selective procedures cognitive preservation is theoretically supposed to be better, but it's associated with vascular injury. Even so-called selective procedures will have, one has to go through neocortex, and then there is a collateral damage. So don't keep worrying about doing different types of selective procedures. If it's not surgeon alone, entire epilepsy team has to evolve to identify very focal origin. So there is definitely a role for selective resections. Selective resection is not only selective amygdalohippocampectomy. There can be selective temporal polectomy. There can be selective temporal, say for example, if there's a lesion or a dysplasia involving the middle front temporal gyrus, you can do selective resections. There is a role for selective resections, but pre-surgical workup also should show that the focus and lesion is confined to a very selective area. And finally, it's not that once surgery is over, everything is done. These people with the drug-resistant epilepsy, they need hand-holding. They need a long-term care. Even after seizures are controlled, they need some sort of support. Some people, once seizures are controlled and then they lack the support, they'll go into some sort of forced normalization. They throw seizures which are actually not genuine. They through pseudo seizures. So they need a long-term psychological support. But if you can, this is a message to young people, if you can cross all these barriers and develop interest and expertise in epilepsy surgery, it is very rewarding. I'm sure you look at Datta, me, and there are about 40, 50 neurosurgeons in India who are involved in epilepsy surgery. It is intellectually, from a technical point of view, it is a very rewarding subspecialty to develop. Pay attention and then develop your interest. And then over to others for comments. I'm not sure whether there anything in the chat box.
No.
Nothing in the chat box. Milind, Ravi, Abhay, your comments, please.
Yeah. Can I ask a question to both of
Yeah.
you,
Sure.
Dr. Majumdar and Bhaskar? You people have such a vast experience in epilepsy surgery. Now, how many of in your series whom we initially thought this is the classical temporal lobe epilepsy or temporal amygdala hippocampal sclerosis? You had done a classical amygdala hippocampectomy with the temporal lobectomy, and over the period of time, maybe after 4 or 5 years, they come back with seizures, and then you found out there was a knot or there was an extra temporal epilepsy focus here.
Uh, I think your question is that in the initial series, temporal lobe semiology can be mimicked by frontal or vice versa. So initially, I think the breaking point is interictal EEG and a long-term video EEG monitoring, and obviously that forms the base on which we ask the radiologist to either look into architecture in detail or maybe serially repeat MRI. So it may be 1.5 3T or take more 3D flares, relaxometries, all these things. So unless that video EEG, the semiology, video EEG, and the long-term this monitoring matches with the MRI, and obviously now the PET has come to a picture. Now PET always shows areas which are more than what is actually needed, or actually see the involvement is high, more than what it actually is there. So PET has to be taken with a little bit with not with we have to think a lot of things when it's PET, but I think PET acts as an adjunct. So all these things, if you see, if we match it, then definitely we reduce our errors. But I don't recollect of when a case where we have operated on the basal temporal lobe and we have found that the region is extratemporal. As I mentioned in one case, when there was a parietal occipital FCD with MTS, then that time obviously we the same reasoning that we removed the FCD, and because there were temporal discharges also, we felt that that also needs to be excised. But today we could do a TP or disconnection. Maybe instead of removing the entire thing. So that is a little bit advanced as compared extratemporal versus temporal. But otherwise, we have not burnt our fingers saying that, okay, we have removed the temporal lobe and now the focus is extratemporal.
I think Abhay, all centers in the world, without exception, had failures. I had failures. But the published outcome of epilepsy surgery programs in countries like India and other developing countries, they seems to be better than established programs in United States and Europe, largely because those who started early, they had more failures, and we read their literature, we read their failures, how they failed, and then we learn from their mistakes, and then we try to avoid. That is one. And second thing, of course, Datta also has mentioned that many of our patients cannot afford, unwilling for resurgery. So we are very careful, and then when we had doubt, like whether this is not a best case, and then there is some features or red flags are there, then we prefer not to operate. We just keep them pending. So we learn from published literature. We are learning on our own, and of course, because of the good teams also, we are trying to avoid the mistakes. Actually, if you see my first 10 cases, every case I went a little bit more into the hippocampus. So gradually over a period of time, we learned how to do complete hippocampal resection. So initially, people will do incomplete resections. Incomplete resections obviously will have surgical failures, and also many other there are studies from India as well as from abroad, that the pathology is not just confined to hippocampus alone. There can be in the neighborhood, temporal neocortex and pole. There can be associated changes are there. If they are left unresected, then also there can be failures. And see, for example, Cleveland Clinic, all their surgical failures they published, and then they called those patients for stereo implantation, and then found that so many people who underwent temporal resections actually had the origin from insula. And even if you read the history of hypothalamic hamartoma surgery, the hamartoma patients before MRI was invented underwent so many focal resections, frontal lobectomy, temporal lobectomy, and all those things. And then later only, when MRI invented and then those surgical failures were evaluated, so many hypothalamic hamartomas were detected. So I think with careful checklist, just like surgical checklist, we can minimize the failures with the currently available technology as well as knowledge base. Over to you, Abhay.
Can I make a comment?
Sure, of course.
Yes, Dr. Sai.
Yeah, so I have a slightly contrarian view. Probably I'm getting into a little contrarian views today, but the question that Abhay asked regarding suppose someone has been operated and 5 to 6 years down the line, the patient has recurrent seizures. I don't think it's a bad result at all. I think it's a good result. One may say, yes, recurrence, reevaluate, all that is fine, but 5 to is class 1 or class 2 like to get into, but it's a good result. So I don't think it's a bad result. So that's one. Second, the Bhaskar mentioned regarding Indian scenario in epilepsy has good results. I actually don't know about that, Bhaskar, because what really limited, and I don't know whether there is a reporting bias as well. So a significant number of times, it's very difficult to find a program which says that their results are not up to the world standards. So most of them would try and make sure that the report results are projected well, and acceptance of failures is slightly difficult for any program. And I think one needs to be a little cautious in saying that, as surgeons in India or as programs in India have evolved better, learning from poor Western experience, I think that's a little very loud statement to make. It's probably better to say that our results are probably as good as others rather than saying that our results are better.
So, Milind, I want to mention that, see, when we started the program, I'm sure Bhaskar has got enormous experience, but we were harping on 1 year, 2 years, 5 years results. But I'm saying that our MTS results, or in general, which were 80%, dropped down to 55, 58%. And that's how the data has been, our data at least, as I just was mentioning, has been extremely scrutinized. It has been scrutinized by a third person. It has not been scrutinized by the surgeon or the epileptologist. It has been scrutinized by a third party. And obviously, I'm saying that the results have dropped. And if you have a results at 10 years, about 55 to 58%, that is a good result. So what we are talking about, that freedom from seizures and complete withdrawal of drugs is about 55 to 58%, which is excellent at 10 years, I feel. But in between, definitely there will be those hiccups where the seizures come, 1 or 2 seizures come. So most of these patients who are not on of drugs may be settled from 3, 4, 5 drugs on 1 or 2 drugs. So that's also a good result. On 1 or 2, if the surgery is epilepsy is controlled, I think it's a great result.
Yeah,
So-
one more point is when we talk about seizure recurrence, there's immediate recurrence. Second one is delayed recurrence. Immediate recurrence, obviously, we have not removed the lesion and focus. They have incomplete resection. So there can be issue with actually selecting suitable patient or selecting suitable surgical approach. But what Milind is mentioning about the delayed late, this one late is because there can be dual pathology. There can be more than one lesion or focus, or there can be secondary epileptogenesis. Some new area could take up, and those recurrences need to be worked up on their own merit. And regarding this outcome data, all these are published, and probably the young members of NCNS can Google search about the outcome of epilepsy surgery from US, Europe, and India, and then make their own conclusions. Abhay, over to you.
Yeah. So one last question, one last in brief. Now let us combine both. What's the role of DBS in epilepsy? In brief, in brief.
Yes, I think definitely the role of DBS in epilepsy is now increasing, I must say. And there are many centers in the US who are doing it on protocol basis or on this thing on trial basis, which they have found encouraging results. But I think we'll have to wait a little bit for longer for the long-term results to come. And the same thing again. Now, just as the debate was there on functional neurosurgery, stimulation versus lesioning, and the same thing is your navigation versus non-navigation for this thing. The same thing would be there. There would be a direct comparison between resective disconnection and DBS. Still, if we break the circuit, but still, as you say, multiple pathways are there. I'm not still sure that DBS for epilepsy to become a standard of care will maybe take a little bit longer time.
Yeah,
I slightly beg to differ on that, Datta. DBS is one needs to try and classify the role for resective and non-resective. DBS is clearly a non-resective procedure. There is no doubt to the fact we are talking about DBS as a method when we are not sure about whether any form of ictal focus can be dealt with, whether it is in the form of resection, whether it is in the form of a lesioning. The bottom line is does DBS have a role to play as far as non-resective surgery? The answer to that is yes, it does have a role to play. The question can be further broken down to what sort of epilepsies can be offered DBS. That is again a major topic for discussion. But to say that DBS is still far away is not true. DBS in epilepsy is here now, and role of antigen nucleus stimulation is established. So is centromedian nucleus is established as well. And for that matter, in the future, there will be much more, including we are talking in terms of closed loop stimulation as well. So, to clearly it is DBS is definitely going to play a role. It is there already, not going to play a role. I think it's unfortunate that in India, we do not do as many. To say that DBS is going to take a long time, no, it is established form of treatment. Definitely an established form of treatment.
Yeah.
No, it is.
So, Abhay, can I go ahead?
Yeah, please go ahead, Bhaskar. Yeah,
So we have 3 to 4 million people with progressed epilepsy in India. At least more than million people who need some sort of surgical intervention. But unfortunately, only 10 to 15% of these potential surgical candidates are actually candidates for any sort of resective surgery. So there is a large pool of people who are not responding to drugs and who are not suitable candidates for resective surgery. Something has to be done. So neuromodulation has got a definite role in taking care of these people. BNS, RNS, DBS, all of them. I think because of our probably economic conditions and probably the disease itself involves more people from lower economic strata, we are not able to put implants or even do laser ablations in these people. But I think definitely with improvement in the economy, awareness, accessibility, neuromodulation will take up in India over the next few years. And especially, two centers in India are making DBS. One is Sri Chitra is developing DBS, and Defense DRDO is developing DBS. And if there is a Indian DBS is available, I'm sure the implantations numbers will increase. That's my take.
Yeah. So
Dr.
as as we were discussing, I mean, there are palliative and resective, curative. So surgical is curative and palliative is neuromodulation. Many neuromodulation procedures are used as palliative surgery. For example, vagal nerve stimulation and DBS. I have done about 3 DBSs for epilepsy, and all of them have improved very significantly, 80 to 90% seizure control. Same with last year, we did about 12 vagal nerve stimulations. So all of these neuromodulation techniques are, as Milan said clearly, is happening, and it's been done, and things are going on fine. Cost is prohibitive. That is one of the reasons. And the most important thing is to localize what type of seizure, how many multifocal seizures. These are things that the epileptologist needs to really work and then decide on which is the appropriate procedure. And then we can take it forward. In fact, the Sante trial, as Milan mentioned, is quite a successful trial.
Can
Yeah,
I talk?
Sure.
Yeah, I agree with this. But see, whenever a new thing comes into an armamentarium, we have to be very careful. We are talking about a long-term control and giving neuromodulation to a large section of patients who are non candidates for non-resection. But I feel we have to maybe wait for some. It is not a technical procedure they were talking that we have done the procedure and the epilepsy is gone. What happens 1 year down the line? What happens 2 years down the line? We are having problems with resective surgery as well. Multiple foci, secondary epileptogenesis, all these things, all these parameters. It is not that I get a good response with DBS for this thing. Okay, it might help for some time. And as you correctly mentioned, it is prohibitively expensive unless we get some. But in those cases, again, will be a wave where many patients may be subjected to this under some reason or the other. And again, we will have the same problem that failures, we have to be very, it has to be a joint, some consortium where we have to decide our outcome parameters, duration and everything. So I think, yes, there is definitely a role, but we have to be cautious.
Yeah, thank you. Over to Akshat. Akshat, go ahead, please.
Thank you everyone for joining us tonight and for your valuable insights as well as sharing the knowledge with us. And with that, I believe Shubham is there from the MCNS team. We can take the MCNS panel can take over from here on. Thank you everyone. Good night.
Yeah, Akshat, I think they are not there. I would take from my side, I would like to thank Dr. Dattatreya Majumdar, Dr. Malla Bhaskar Rao, Dr. Verma, and Dr. Sankhe for participating today. We'll close the session. Yeah, thank you. Thank you very much.
Thank you. It is always a pleasure to learn from Bhaskar, Ravi, Milind. They are all
always
very good time.
always.
Yeah. Thank you.
Thank you very much.
Good night.
Bye.
And a happy New Year to all of you.
Happy New Year. Happy New Year. Yeah.
Bye.
By the way, I have a comment regarding what was the pleasure that MCNS had in arranging a webinar series on a 30th evening on a Saturday evening. Guys, come on, MCNS needs a break on this, man.
Yeah.
Sorry, Milind, I tried my best to stop this, but Majumdar didn't help me in this. you had to blame.
You thought that I would have helped. I would have openly helped.
Some pleasure, man.
Milind, night is still young, Milind. We can get out right now.
Yeah. I generally get to bed by about 10:30.
Abba, you wanted my help. I didn't realize that.
Yeah.
Okay.
Yeah.
Okay, guys.
Thank you all.
Good
Thank you.
night.
Good night.